I sort of wanted to take you on this sort of journey of thinking about using areas of WASH and in particular hand hygiene to illuminate dimensions of quality of care, and for us to really recognise this is, when you talk about WASH in facilities, it needs to be integrated and seen as part of quality of care, quality improvement, quality assurance. And I have some concerns from the sort of territory I'm in at the moment with UNICEF and others that we're getting a little bit siloed with WASH, and this will not, in my view, we'll lose benefit of WASH in facilities. So there's a really important issue here. So macro to micro, and here I am down with the microbes now from a very, very large picture. So it's been an interesting journey, and it's taken me into areas, the connection between the macro and the micro is actually quality of care. So in focusing on reducing maternal mortality, quality of care is key. And then if you use a microscope to look at quality of care, you can go down to some issues which sort of really help you understand the dynamics at lots of levels. So for me, it's a real exemplar and helps us really cope with some of the complexity. Starting off with context, what do we mean by quality? And I'm using quality of care to mean the system, the service and the care. So I use quality of care in that general sense. I'm going to talk about WASH from a sort of big picture point of view. Then I'm going to do, I hope, what I think is rather novel, I hope, which is to walk you through a facility to illuminate the areas of where quality is an issue, but focusing particularly on WASH and these. Then going on to some experiences in 5 countries I've been involved in the last 3 years, and then of course the conversation at the end. So quality of care clearly matters. It matters, and increasingly so, increasingly so. We've always known it's on the crucial pathway to reduce maternal and newborn mortality and improve maternal and newborn health. Quality is that sort of intermediate but absolutely crucial element in that pathway to making a difference. Obviously there are broader distal determinants, you know, status of women and many other issues, but quality of care is really, really key. And I think many of you will know that there have been recent assessments that have looked at both the supply side and the demand side, you know, what women think about care, and shown some rather alarming findings. Now, this is getting increasingly important because institutional delivery rates are increasing globally. We're past the 50% tipping point. This is just 4 countries showing you trajectories. Ethiopia, actually, it's a little bit steeper than that now. Some of that acceleration is really dramatic. Ethiopia is an example, increasing in a way that's outstripping capacity and responsiveness of the system in many places, leading to not just the benefits of institutional delivery, but potentially perverse effects and disadvantage. And that's not what we want. Of course, this sort of intervention should be moving us in the direction of health gain, less mortality, less morbidity, but there are risks if the quality and particularly the issues around WASH are not addressed. Okay, so a lot of people talk about quality of care as being complex, and I know I'm interested in complex interventions, but I think it's better to describe it as composite. Composite. Quality of care, whether you're talking about the systems, the services, or the clinical care, technical level, is basically made up of lots of different levels and lots of different tiers, so it can be at a very macro level right the way through to micro, and it's got lots of different dimensions. And one of the simplest frameworks is this one, you all know, Obedience, which sort of breaks it down into structures, process and outcome. And the point is that whatever framework you use, WASH, meaning water, sanitation and hygiene, everybody's very familiar with what that terminology means, is a core part of quality of care. And whether you use this sort of model that's sort of breaking it down to the demand side or the supply side, again, water, sanitation and hygiene, both the supply of water, the quality of the water if it's drinking, the availability of sanitation of a certain standard, but also hygiene. Not only these, you're seeing my hands possibly, I'm waving my hands, but also the hygiene, the cleanliness, as it were, of the environment. So there are lots of different definitions, and the learning resources talks a lot about those. There are other ways of bringing it much more dramatically to the forefront of our attention, and this is what I call image evidence, and I use it a lot these days. I'm not done with the numbers or the statistics or the tables, of course, but I think there's power in using images advisedly. This is actually an image from Ruth Lawson, who very kind with permission to use it. And I think it shows very dramatically what quality is not, or rather this is an environment, a birthing unit, where it certainly doesn't meet the expected standards. You can just see from the environment who would want to practice there. What sort of practice could you undertake in that sort of environment, and what would it mean from a woman's point of view as well to be asked to deliver in this environment? So we can use image evidence, and I'm going to use some more. Going to WASH, of course, there are experts in this room. I feel very embarrassed to be summarising it so very briefly, but we do know that WASH is important in its own right beyond in facilities. We know that it has broader issues linked to WASH and maternal health and newborn health as well. There are broader issues that go beyond the context of health facilities. So the issue of lack of access to water and sanitation, its impact on girls going to school. So there's a lot of understanding of that. And then, of course, at another level, there's this more direct link. So you could say the top are sort of distal determinants, but very important. This issue of contamination, infections, and behaviour. And some of you will know that there is work that's been carried out, this work by colleagues at the London School, showing that the impact of WASH should be seen in a life course. So I'm just talking about a particular moment, the moment of delivery. In my view, of course, I'm biased. I think that's a really crucial moment, and prevention is better than cure. It's a crucial moment, but of course the WASH picture, and WASH is actually a much bigger context than what I'm talking about. However, within WASH in health facilities, as I said, I am concerned that it's not being positioned, particularly when we start talking about universal health coverage, in a way that's going to achieve the gains that improve water, sanitation and hygiene, and even more specific issues around hand hygiene actually make a difference. Now, again, we know something about what's happening in health facilities. There's been a number of large assessments. WHO and UNICEF did one recently. 66,000 facilities. This is not that. This is from somewhere else. 66,000 facilities, low and middle income countries, showing that only less than a third of those facilities did not meet criteria for what we call WATSAN, which is, again, something I don't need to go into in the interests of time. But this is a very interesting one because it's taken from Tanzania, and it's basically showing you for 3 types of facilities: hospital, health centre and dispensary. The light blue is the overall level, to what extent those facilities met WATSAN criteria. But if you look at the labour ward, the overall average was 44%, and the labour ward is lower, or half of that almost. And in my experience, in doing assessments across a large number of facilities, I am seeing the raw end of the continuum, as it were. I think there are big issues about why that is. I've spoken to many architects. I know we have, is it Paul, who knows a lot about infrastructure. I've spoken to architects of hospital who talk about the need for the maternity unit to be separate. That means it's sometimes at the end of the mains run, etc., etc. So there are big issues that help to explain this scenario. But this clearly, again, to go back to the opportunity to make a difference, let's get ahead of the curve of institutional delivery and make sure in having women wanting, being mobilised to deliver in facilities, they are not being faced on the labour ward, nor healthcare providers. And there's clear evidence, the poorer the environment, the poorer your standard of practice. So let's really get on top. This is not a minor issue. To me, WASH, as I said, is one part of this Venn diagram, and it overlaps with quality of care. And quality of care is clearly more than WASH, so whether I've quite got the Venn diagrams correctly, I'm not sure. But the piece I'm talking about is that overlapping interface. And I think there is a really missed opportunity to position this more closely. What I see in a lot of the conversations about WASH in health facilities is not using the narrative, the language, the opportunities that we have, the issues when we talk about quality of care, in particular issues around infection prevention and control, issues of quality assurance, issues of patient safety. There's a set of platforms and instruments that we use in looking at quality improvement, assurance. It's a narrative. If you go to healthcare providers, ministers, healthcare program managers, they will use this language of these boxes. I've got these extra circles here. IPC, not interpersonal communication, infection prevention and control. But I don't see that language so much in WASH, and as I said, my main message is, maybe I should just stop at that message, is that there's a missed opportunity here. We need to have the two working more closely together. Prevention, absolutely key. First, do no harm. The whole issue of this opportunity to look at interventions, they're very meaningful, both for women, for providers, and for the Minister of Health. The sort of picture I showed a minute ago of the birthing room speaks volume. I could have shown table after table after table. For me, image evidence carries massive power. So I'm sure I'm preaching to the converted, and I could just stop the next whole section and jump a large number of slides. And what I wanted to do is take you through what I call a walkthrough. And walkthrough methodology is what I use a lot with partners in country, working particularly with WaterAid these days. We do work with the NHS, who give us infection prevention and control support, working intensively in 5 countries. But what I want to do, and I can do it quite quickly, so if you want to really feel the context of this, let me walk you through a facility. And apologies, because I know amongst us we've got people who've practiced in facilities who have done this sort of thing for many years, and some of this will be very real for you, and some of it may be a bit of an eye-opener, so bear with me. So all of these images are tough, many of them. They've all been taken with permission for the purposes I'm using today, but some of them are tough. So let's start off the picture. Here we are at the beginning of the hospital, finding our way into the maternity unit and the paediatric, noticing they're next to the mortuary. And we also see in the background that maintenance is perhaps an issue. I've worked in quite a few countries now where the word maintenance actually doesn't have a obvious translation. The Gambia, for example, there's no word in Wolof for maintenance. So issues as you go into the entrance to the hospital. You walk through the corridors on the way to the maternity hospital towards the morgue. I'm not entirely sure if you can see all of that, but you can see infrastructure problematic, trying to keep services running at the same time as providing care. Sometimes wards are emptied and sometimes the maintenance carries on or the refurbishment happens at the same time. You get to the maternity unit, the first ward is empty, there are issues of mattresses, no mattresses on beds, and some presence of somebody who has obviously had a chance to have a mattress. So starting to get some sense of where we're going into. We notice a woman who's come for labour having to use this basin. This is local innovation, no pipes, water comes in at the top, it's gathered in a bucket, it's poured in back over the top, no pipes on the labour ward. Local innovation, not ideal, been like that for a long while. You carry on and you notice sinks that you really don't want to wash your hands in. These are sinks that are still supposed to be functioning and will be counted in a wash assessment, but actually the tap doesn't work and clearly haven't been cleaned for a while. You ask about the toilet. The labour ward toilet is outside. There have been problems with the latrines. They're backed up and they can't use them. They have a pit latrine outside the labour ward. Onto the labour ward, very crowded, one midwife on duty at this particular time. Many women asked to bring bleach with them, some mattresses with cloths, some with plastic sheets, but clearly the midwife trying her hardest in a very crowded environment. This is institutional delivery that's gone up markedly without the capacity of the system to respond. So you go through to the actual delivery room, and you wonder what is happening. Onward, after delivery, post-delivery, a woman remaining with a baby, keeping together, good practice, no cover on the bed, but she has a kanga to sort of put down for herself and the baby. Very little sort of other support in that area. But you do notice afterwards that there are lots of floor patients in other areas, 2 or 3 to the bed. This is not good post-delivery infection control by any means, but giving you a sense. And also you notice that the babies sometimes have to be taken away because there is a problem of floor patients, and sick and well babies are sharing bassinets in an area. So this is the context of infection prevention and control. This is the real physical environment. You notice someone washing their hands. The water is on at the moment, so that's great. The pump, electric pump, hasn't been working. Water is on. There is this liquid soap, which is actually fairy liquid or the equivalent. You also notice that they've now got some gloves. There's been a hand stock out. Hand hygiene is not just hand washing, of course. It's alcohol hand rub, or it could be and or glove use. Some gloves, but the wrong size, and some issues of infrastructure. The cleaners, the forgotten class of the healthcare workforce. Doing a deep clean of a facility, the supervisor, shortage of cleaners, supervisor taking part as well, no real protective clothing for themselves, certainly not footwear to do what they're needing to do. And you look at the cleaner's cupboard and you see there are buckets now, but the bucket won't fit underneath that tap. So there are still complicated mechanisms for doing the cleaning. You notice another part where the mops are still not being good practice. The science of mops requires them to be hung up so that they dry properly. And the science of mops has to have filaments as well, not big t-shirts tied on the end of a stick or a cloth. And you hear about counterfeit bleach as well. The laundry. The water's been off for a while. Laundry is hand washed. But there's a backlog when the water doesn't work. These are, again, laundry staff. Who talks about the laundry staff? Doing jobs without any protective equipment, clothing. You meet the staff and you wonder how they carry on. And you hear about, it's very hard to change a behaviour like hand hygiene if the infrastructure keeps changing. You can motivate, you can put your posters up. But if there are periods when the infrastructure doesn't meet that requirement, it's very hard for them. You meet the cleaner who's never been trained, who tries to understand the idea of microbes and infection, has never had formal training, has recently used her own money to buy mops. There are big issues about the word cleaning and the cultural significance of word cleaner and the cleaning class, as they're sometimes called. Very problematic. You notice women within the facility talking about the importance of hand hygiene when you go home, for cord care as well. So that's very good. Of course, many of the women are saying they do have challenges with water at home as well. And you notice the management of the hospital recognises it's very important to have a clean environment. And so you go from that sort of walk through, so as you leave the facility, you notice that there's a spirit is willing. But the threat of external inspection, I mean, having worked on maternal mortality for so many years, I never expected a subject to be more sensitive. And infection, hygiene, hand hygiene is highly sensitive. And it raises big issues for monitoring. External monitoring presents a number of problems. So when we do very large-scale monitoring exercises, we are not getting close always to the truth. It has to come from within. Self-assessment is the basis of quality improvement and assurance. And there is an issue about monitoring methodologies that needs to be addressed. And so that's a sort of big question. So it is about these, ladies and gentlemen. I'm shaking my hands, oddly, after all these years in obstetrics and back to hands. But it is agents of great good and agents potentially of disease, and highly, highly significant. So healthcare-associated infections, we know, not from there are systematic reviews in low-income countries that are showing you creeping up prevalence of healthcare-associated infections, not just on maternity, but wound infection, etc. We have a major audit going on caesarean wound infection, which shows some very staggering levels of wound infection. But I think here in Europe, for example, about 7 billion euros a year are direct healthcare costs related to healthcare-associated infections. So this is not a trivial issue. It's not a trivial issue. For the maternal fraction, maternal and newborn, we know that probably in the order of 1 million deaths directly related to issues around unclean birth. Of course, not just facilities, clean birth at home as well. But recent assessments from a number of countries have shown actually that proportion is higher. One of the difficulties is the infections happen after a woman has gone home from a facility delivery, and your monitoring mechanism doesn't always pick up. And the number of surveys that don't make the connection between where did the woman deliver? Isn't that a basic question that we should be asking? So I know it sounds like I'm having a downer, but there's such opportunity to make a difference. And I have to say, I mean, that for me has given me like a second or third lease of life, an opportunity to make a difference. So hand hygiene, in the last, what I hope might be about 10 minutes to run through the last bit. Why have I chosen this? And I think it's because it does show, it's sort of an entry point for looking at some what can seem overwhelming, complex, multifaceted issues. And I do believe that issue of starting with something which is amenable to change and leads to real feelings of motivation amongst staff. So it might seem very micro, but actually it speaks to these many different elements. The whole fact of it can be micro to macro. It means everything from infrastructure to behaviour. There's all sorts of issues about connecting. When you look at wash and hand hygiene, you can also make connections to many other areas beyond the facility. There's this preventive opportunity and monitoring opportunity by using the lens of hand hygiene. Wash, but particularly hand hygiene is what we've been looking at in particular. And what I'm going to do is report on something that I've been doing for the last 3 years, an initiative called the Soapbox Collaborative. An interesting story, but I won't bore you with it. But basically, we're working in partnership with a number of agencies in 5 major countries, are very much focused on this issue of wash in health facilities, particularly the maternity unit, and particularly areas of cleaning the environment, cleaners. We have a competition for the better word for cleaning, and the whole issue of hand hygiene. Implications and conclusions, and of course I know that DFID has been developing a concept note about wash in health facilities. I had a chance to have a quick look at it just so that I had some sort of context for this conversation, and I think that issue in that concept note breaks it down into sort of policies and programs and sort of research and evidence. So let me sort of use that. So this issue for me is this call to action. This is a paper, I think I included it in the attachment. This was working with a whole series of individuals. I was just one of them, WaterAid, UNICEF, WHO, etc., etc. But I think this is an example of trying to make the link with quality of care, but it's not, it's still, this was published at the end of 2014. I still, when I look at the conversations on universal health coverage and I see the word quality, I still often don't see the connectivity with WASH. Now, it may be happening in some areas, but I would say for DFID as a development agency, as it were, this is a fantastic opportunity to make that connection with the agenda around universal health coverage. We want universal health coverage of quality care, and WASH is a core part of quality of care. That is the way I feel, and I'm not alone in this, I'm making that pitch today, but there are many others who feel, again, it's this missed opportunity. And it goes back a very long way. I mean, I think it brings up issues of monitoring. You know, this is a quote taken from the 1970s, is we must link up the monitoring. People will not be convinced unless we also do monitoring from within facilities, including down to the microbes level. Environmental hygiene, environmental cleaning, environmental monitoring has got neglected. We had a great problem finding the capacity of laboratories to do this. The local hospital could do blood types and HIV testing, but we asked about environmental monitoring and it was a gap. It was a gap. A great gap to fill. And again, it goes back to monitoring, you know, looking at to what extent the standards, the facilities are available. You know, starting here in India, in Gujarat state, it got picked up, you know, Prime Minister Modi and his Clean India campaign, this was all happening at the same time. And so there was an environment of policy that said, let's start to introduce routine monitoring that can really make a difference. This is something we can relate to. It affects the performance of providers. It has relevance to us, those at a policy making level. So as I said, it has been a voyage of discovery. There's much more I could send to you and provide to you. It's a bit of a snapshot. The connection to the learning resource, and Adrian and the team have worked on that learning resource. This is a slide you can come back to. We'll obviously leave the slides for you, showing you which parts of the learning resource relate to what the WASH element. I think we probably could strengthen the learning resource in that area. I think we recognise this. I think the last message is what you've seen me do before, and as we've been here before, we know that there were moments in history when the mortality for mothers and babies was 4 times higher. This is Glasgow Royal Maternity Hospital in 1910. It was a time when we sort of knew about microbes, Semmelweis and Wendell Holmes, etc. We didn't know so much about antibiotics at this point, but basically there was a missed opportunity to make a difference. Now we do know about the importance of this. The question is making it happen. And for me, as I said, on this voyage of discovery, it's about, there's a mantra in the NHS, my NHS colleagues, no change is too small. Sometimes we need to tackle it from the bottom up. There is great sensitivity with external assessments that take us not close to the truth. But at the end of the day, if you want to impact in terms of these infections, it needs to be a bottom-up approach and a top-down. They need to meet in the middle. And there is an issue, with improvements, the sort of interventions that we're involved in now, which might sound micro, like environmental swabbing and training the laboratories to do environmental swabbing. That is change that I think is the sort of thing that both our public and our ministers can really appreciate and recognise and relate to. So, apologies for the rapid pace of that. I hope the enthusiasm came through, and thank you for listening.